Okay, hi everyone. My name is Alex. I'm a CIP resident from general surgery. Here are my disclosures, and I'd like to thank CIP for supporting this work. So when I first started using ChatGPT, I actually asked it to write an operative note for a general surgery procedure, and this is what it gave me. It gave me very specific findings like the redundant subhepatic mesentery with focal tethering and intricate techniques like how the mesenteric fold and peritoneal reflections were decorticated. And the general surgeons here must be scratching their heads because this is complete nonsense. There's no such thing as a subhepatic peritoneal decortication. But the point I'm trying to make is that ChatGPT was able to make it sound so convincing using surgical jargon that is real, but combined together is in a way that's just completely wrong. And despite our concerns with AI, like hallucinations and privacy issues, AI is being adopted at a rapid pace. More than 70% of physicians use AI in some form, and more than half of healthcare organizations are already adopting AI into their workflows. People already believe in AI regardless of existing concerns. And generative AI, specifically large language models, are increasingly adopted for their efficiency. LLMs can decrease time for documentation compared to residents, for example. It can improve timeliness for patient communication with automated messages, and their perceived quality is just as good or even better compared to human notes. And this presents a major opportunity for emergency general surgery, which is a demanding 24-hour service delivering surgical care to critically ill patients. In this fast-paced environment, surgeons struggle to keep up with documentation and end up spending 60% more time on the electronic health record compared to the elective counterparts. So by automating operative note generation within a busy and complex surgical specialty, LLMs present a significant opportunity to improve efficiency. So we want to see how good are LLMs in operative note generation. So our study aimed to evaluate LLM-generated operative notes, assessing their performance across varying levels of procedural complexity in emergency general surgery. And in doing so, we wanted to guide future adoption of AI in acute surgical care. So we evaluated the 5 leading publicly available large language models, ChatGPT, DeepSeek, Grok, Claude, and Gemini. And to simulate real-world use by individual surgeons, each model received only 3 key inputs: the procedure, the diagnosis, and very brief relevant medical history. Supplying additional information would increase time and reduce efficiency, undermining the intended benefits of LLMs. And we selected 3 representative procedures for the LLMs to generate: inguinal hernia repair for its distinct anatomical landmarks, acute biliary disease for its critical operative steps, essential to patient safety, and bowel obstruction for its variability in intraoperative findings and required surgical approaches. We designed 3 surgical scenarios for each procedure, reflecting increasing levels of complexity: standard cases, your uncomplicated cases, and then intermediate cases with minor deviations, and high complexity cases involving major complications or acute presentations. Each of the 5 LLMs generated notes for all 3 procedures across 3 complexity levels, producing a total of 45 operative notes. And then each note was then evaluated across 5 domains on a Likert scale. These included accuracy, referring to the anatomical and medical correctness; procedural fidelity, assessing the logical sequence of required steps; and detail, evaluating the level of nuance and reasoning behind key decisions and techniques; and documentation quality, reflecting the formatting of the note; and then overall surgeon preference. So each note had a total maximum score of 25. 2 raters were blinded and independently scored all 45 notes. We analyzed the scores across different levels of procedural complexity, scoring domains, and LLM models. And we also collected qualitative feedback on the generated notes. So who came out on top? Well, all the 5 LLMs did comparably well. Grok showed maybe a slight edge, but no statistically significant differences. And then that was true for the procedure types as well. There are no differences here. But then when you look at across scoring domains, there were differences in performance. LLMs performed well in factual accuracy, making the note look nice. But when it came to detailing procedural steps and explaining the rationale behind key decision, their performance declined. And naturally, surgeon preference also declined as well. And we can see the reason behind this when we stratify based on procedure complexity levels. When a procedure deviates from the norm, LLMs begin to omit key findings and decisions, often leading to incorrect procedural steps. For example, when asked to generate a note on bowel perforation requiring an emergency laparotomy and open abdomen, the LLM fails to take into the context a patient in shock requiring damage control surgery compared to a definitive repair. And the LLM actually went against the prompt, saying the bowel was anastomosed and the abdomen was closed. And as a result, you can see the overall performance declines with higher complexity procedures. So based on all these findings, we can say that first, most generative AI models seemingly do well and they sound nice. But when we look closer, the nuances are missing. Many of the quality comments highlight the lack of reasoning, rationale, and detail behind key decisions and findings, often leading to inappropriate steps. Simply put, the models can generate notes that look and sound good, but they fail to capture the complexity of the case. And this problem can only be amplified by poorly adopted AI tools. Data from CMPA shows that general surgeons still face medical legal vulnerabilities at the same rate as before, and inadequate documentation consistently ranks as one of the top contributing factors. Nevertheless, we're adopting AI, we're rushing to adopt these technologies. The future is already here, but how do we make sure it's good and what's missing? Well, I would argue that we need to return to our foundations. A recent New England Journal of Medicine paper described an important phenomenon. When AI is introduced too early to novice learners or those with weaker clinical grounding, they risk accepting its output as absolute truth, leading to over-reliance and de-skilling of critical thinking. But when AI is layered on top of a strong clinical foundation, users can actually critically assess its outputs and incorporate it into its practice. So I would argue that technology adoption, AI adoption, is really a profoundly human endeavor that depends on a good understanding of physiology, pathology, human empathy, and real-world clinical practice. As next steps, we will be studying the medical legal implications of AI technology, create a framework for AI engagement, evaluation, and education, and move surgeons to the front lines of innovation, not only to keep pace with these advancements, but ensure their safety and ability to enhance care. Thank you.
Any questions for Dr. Lee? I'll start. So how does these Gen AI agents compare to residence notes?
Yeah, the studies are mixed for now, but some studies show that the generative AI can produce notes faster. The perceived quality is comparable or sometimes even better. So in a way, they're heading towards sort of replacing some of those workflows and documentation. But as you can see, when the procedures get more, or the notes or the procedures or the context gets more complex, the AI models tend to do worse in that case.
Who mentors a resident in their notes? Does a preceptor look at their notes?
They're supposed to. But sometimes that doesn't happen. Yeah.
What is the proposed time that may be saved through the use of AI?
Great question. That's also mixed. Some studies actually show that the time doesn't improve consistently, but rather the users feel better when they use AI. But now the studies are beginning to show that there are some improvements in time, maybe 30% to 60% from the studies I've seen. But because they also feel better about documentation, it actually ends up being a significant improvement, even if it's like a small margin of difference. Yeah.
Sorry, thank you. The question was just about complex cases and how accuracy degenerates with those more complex cases. Is it just a matter of spending more time with the AI and training it to be able to recognize it, or is it some other element of it that needs, or maybe once you have a complex case, you're just not using AI to dictate?
Yeah, I mean, that's hard. I think with more data, it will probably get better and better, and especially if you give it more sort of complex cases and notes, and the more it's trained on them, the AI might get better. But, AI is not, at this point at least, like, it's not necessarily thinking like humans, going through the rational and logical steps of a complex procedure. I think human input is where it's still needed, where you can quickly assess, as we saw, like, are the procedural steps making sense? Are the details and nuance and the rationale behind the notes making sense? It's also medical legally defensible. There's a lot of considerations that go into a good note, I think. So I don't think AI will completely replace it at this point, but yeah.
I just had a question too about, you were mentioning too that the dangers maybe lie more in the more inexperienced or junior residents or junior staff adopting this readily before they have experience. So I have two sort of questions. One, do you find that for those who are overseeing those residents, does it end up being more work because they're having to parse through looking for errors in the notes from a, AI generated note? Is that happening? And the other thing, is this potentially an area where we have to bring in some controls? Like, when do we sort of introduce this in the learning process for surgeons, for example?
Yeah, that's a great question. Yeah, it is happening. People are describing that sometimes it's more work to fix these errors. But that New England Journal of Medicine paper also describes an educational framework to teach around, because residents will use AI no matter what you tell them. So I think there's a way to actually assess the AI outputs together with the resident, go through sort of the reasoning with the resident, and try to gauge and fix any errors together. And I think that helps with the residents' learning as well as the attendings' learning as well. Thank you.
Thank you.